Hello, this is Dr. Donna Ryan, Professor Emerita from the Pennington Biomedical Research Center. Welcome to this educational activity on patient-centered treatment of obesity and the evolving role of incretin-based weight loss pharmacotherapy. When genetically susceptible individuals are exposed to an obesogenic environment, one with ready access to highly palatable, energy-dense foods, and a work and play environment that do not require much physical activity, excess fat gain is the result. But this simple explanation belies what is really a complex interaction between physiological, behavioral, genetic, and environmental factors. Known drivers of weight gain include medications we use for other chronic diseases like diabetes and depression, poor sleep habits, exposure to endocrine disruptors, stress, and many more. Obesity is complex, and we will learn about why it's chronic. To understand obesity, we need to understand the biology of food intake and body weight regulation. We don't have to remind ourselves to eat. The brain integrates signals from the environment and from our bodies and drives eating behavior through our perceptions of appetite, and it also controls our metabolic rate. Let's look at this animation for an explanation.
The hypothalamus is the central coordinator of food intake. Neurons in the arcuate nucleus regulate energy expenditure and intake. Additional areas of the brain also influence food intake, including those controlling reward, emotion, memory, attention, and cognition, and of these, cognitive decision-making has a smaller role. The gut-brain axis regulates hunger and satiety. Ghrelin is the hunger hormone. When food enters the stomach, it triggers the stretch receptors. As food moves into the intestine, incretins are released. Once food is absorbed, the pancreas releases amylin and insulin, signaling satiety. GLP-1 is released by the gut with food intake and also signals satiety. GLP-1 receptors are found in the vagus nerve terminals and throughout the brain. The brain senses energy stores through leptin. If fat mass is lost, leptin falls, signaling the brain to prevent starvation. Hunger increases, satiety decreases, and the metabolic rate slows. This causes weight regain.
Let's talk about why obesity is a chronic disease. Most people know the story of The Biggest Loser television show. We've been fortunate to study the participants in this program, and they have been chronicled in the press. Here's Danny. He lost 239 pounds in just 9 months and won the contest. But when followed up 6 years later, he had regained, despite his very best efforts, and most other contestants did too. After successful weight loss, our bodies fight to regain. It's a defense against starvation. Both energy expenditure and energy intake are affected. Following weight loss, the Biggest Loser contestants all had reductions in resting metabolic rate, greater than would be predicted just from their smaller size. This is called metabolic adaptation. In Danny's case, his body burns 800 fewer calories than expected. And that's not all. In the reduced state, the hunger hormone ghrelin is higher and not suppressed as much by meals, and the satiety hormones are lower. Thus, after weight loss, we are driven to eat more, and our metabolism is lower to conserve energy, and we often regain, unless we have specific strategies against this metabolic and biologic adaptation. The good news is that we don't need to create the extraordinary weight losses demonstrated in the Biggest Loser contestants to produce great health benefits. Even modest weight loss of 3 to 5% brings a lot of health improvements and is easier to maintain. But it takes more weight loss for some improvements, like improving symptoms of obstructive sleep apnea and the inflammation in NASH and reversing diabetes. The reason moderate weight loss has such powerful effects is because abnormal and ectopic fat is lost preferentially. 10% weight loss is associated with 30% loss of visceral adipose tissue. Obesity is a clinical diagnosis. According to the World Health Organization, it is excess abnormal body fat which may impair health. The BMI is a screening tool. For those with a BMI of 25 or higher, we look for evidence of excess fat with waist circumference, and for impaired health with assessment of metabolic and cardiovascular risk factors. For patients with weight-related health complications, we need to offer medical weight loss assistance, provided we can engage the patients. All obesity treatment must be patient-centric. Lifestyle is foundational to obesity management. We want to create negative energy balance to lose weight by changing behaviors around food intake and physical activity. We want to achieve negative energy balance, usually 500 to 750 kilocalories per day, in the initial weight loss effort. At the same time, we need to get our mostly sedentary patients moving. We use techniques of self-monitoring, goal setting, problem solving, stimulus control, and other behavioral techniques to make these diet and lifestyle changes. Let's hear from a patient and hear what she would like to share with us.
Thank you. I'm Christy Gallagher, and I live in Alexandria, Virginia, and work at George Washington University. In the past, I've done various different programs like WW, which is Weight Watchers. I've also did a program, another program that was an online program to try and address my weight. When I would go for my annual visits with my doctor, she would often say, what are you doing? And I'm like, well, trying to eat better. She said, well, what about exercise? And I said, well, I walk. And she said, maybe I should walk a little bit faster. So I was sort of addressing it in the ways that we all think that you need to do it. So, eating better, trying to eat smaller meals, exercising. The one program I did do, I learned a lot about how I was an eater, like that I was a stress eater and that I often would want to eat to reward myself even. So like on a Friday after a tough week, let's go out for ice cream kind of thing. So I learned how to address that with other things like let's go get pedicures instead of ice cream. So that's sort of how I addressed it in the past.
Thank you, Christy, for sharing those valuable insights. But even with our gold standard lifestyle interventions, not everyone can lose enough weight to achieve health benefits. And as we have discussed, maintaining that hard-won weight loss is difficult. When needed, we can intensify our efforts. We can increase patient contact, add more structure to the diet with meal replacements, promote group support, and use our technologies to aid in self-monitoring. Most anti-obesity medications work through biology to help patients with appetite so patients can better adhere to their weight loss efforts. And bariatric surgery has biologic effects on appetite. It produces more weight loss, but requires lifelong nutritional monitoring and support. We need to intensify our efforts and use medications and refer to surgery more often rather than watching patients fail to meet goals. One good thing about medications and bariatric surgery is that they are helpful in maintaining lost weight. We want to prescribe medications to help our patients better adhere to their weight loss efforts. Anti-obesity medications are indicated for individuals with a BMI of 27 and up with one or more obesity-related complications, or with a BMI of 30 or higher. Both the American Association of Clinical Endocrinologists and the Endocrine Society endorse the use of medications over the long term to help patients achieve and sustain health benefits. Here are our current options for long-term obesity management. Orlistat is a pancreatic and gastric lipase inhibitor. It blocks fat absorption. Phentermine topiramate, naltrexone bupropion, and liraglutide 3 milligrams all work through appetite. Phentermine topiramate ER consists of topiramate, a GABA receptor modulator, and phentermine, a norepinephrine-releasing agent. Phentermine is sometimes used for short-term weight management, but it is not approved for long-term weight management. Naltrexone-bupropion combination consists of naltrexone, an opioid antagonist, and bupropion, a dopamine norepinephrine reuptake inhibitor. Naltrexone does not produce weight loss, but it potentiates the weight loss action with bupropion. Phentermine topiramate and naltrexone bupropion were developed based upon the observation of weight loss associated with these older drugs. But liraglutide 3 milligrams is the first drug to be developed based upon our advanced understanding of the biology of food intake regulation. There will be many other molecules to come. Liraglutide 3 milligrams is a GLP-1 receptor analog or agonist. It has dual mechanisms both on appetite regulation and glycemia. Semaglutide is a GLP-1 analog given once weekly. The incretins, hormones released by the small intestine after a meal, have been used as a basis for drug development. GLP-1 is the incretin that has produced drugs that are GLP-1 analogs for diabetes and weight management. GLP-1 analogs with weight management indications include liraglutide and semaglutide 2.4 milligrams. Semaglutide is a GLP-1 analog given once weekly by injection. It's approved for weight management at a dose of 2.4 milligrams weekly. In weight loss studies, patients are given a lifestyle intervention and randomly assigned to drug or placebo. The weight loss achieved with placebo is a reflection of the intensity of the lifestyle intervention. The mean weight loss with our anti-obesity medications that affect appetite, phentermine topiramate, naltrexone bupropion, and liraglutide 3 milligrams, range from 4 to 8% above placebo. For semaglutide, the mean weight loss is greater. Mean weight losses of 15 to 17% with this drug make it a welcome and exciting addition. And of course, greater weight loss with medications compared to placebo means more improvement in risk factors. Remember, health benefits are what we're after in our weight loss efforts. All of the anti-obesity medications produce improvements in health-related quality of life. Orlistat, phentermine topiramate, and liraglutide have shown efficacy in diabetes prevention and all improve glycemia. But liraglutide has dual actions on weight and glycemia and therefore produces the greatest mean reduction in A1C. Phentermine topiramate and liraglutide have shown improvements in symptoms of obstructive sleep apnea. And for the anti-obesity medications approved for long-term use, evidence would support that there is no increase in cardiovascular risk. Although there is no dedicated cardiovascular outcome trial with liraglutide 3 milligrams, a cardiovascular outcome trial with liraglutide 1.8 milligrams was associated with a reduction in cardiovascular events. Thus far, the publications about semaglutide 2.4 milligrams indicate a safety and tolerability profile similar to liraglutide. There are now 2 medications approved for use in adolescent obesity, orlistat and liraglutide 3 milligrams. The age requirement is 12 years and up. In both cases, the safety profile is similar to adults. For efficacy, in a trial with orlistat, 19% of adolescents compared to 11.7% on placebo achieved 5% or more weight loss. With liraglutide, 43.3% achieved 5% or more weight loss compared to 18.7% on placebo. As a reminder, liraglutide 3 milligrams has not been evaluated in pediatric patients with type 2 diabetes. Not every patient responds to this drug or any other for obesity management, and we will need to develop additional options for patients who are non-responders and will also need to focus on exercise to preserve lean mass during weight loss. Every patient is unique, and every weight loss journey is unique. Let's hear what Christy has to say about this.
When I had that appointment with my doctor where sort of came in armed with some knowledge about what I wanted to do and asking her if she'd be willing to prescribe medication for weight loss, I had a couple questions about side effects, whether they would impact other medications that I am currently on. I suffer from migraines, and so I do take a lot of preventative medications for migraines. So I was interested in that. I'm about the age where I'm going to start menopause, and so I was curious about that, whether there are any impacts on any of the medications. And a big thing for me was that, it was covered by my medical insurance that I get through work. And so I'd done a little bit of research ahead of time, but I obviously wanted to hear from my primary care doctor, both whether she had prescribed this medication in the past or the two medications that I knew were covered, and then whether she had any concerns about it for me personally. So I started one, and I do, it's been about a year and a half now, I think. I started it around October. It's an injectable. I use it every single night. There's really no side effects at this point, but there were quite a lot in the beginning. So I had to understand that was going to get better and to keep, plugging through it. I also realized that, and my doctor prescribed it this way, that you start at a very low dose and move up very, very slowly to get to the dose that is recommended.
Weight management is shared disease management. Start by taking a history of what has worked in the past. The treatment journey is one that the patient must endorse, so the provider's job is to counsel on what is safe and what is likely to be effective. Prescribers must monitor pharmacotherapy for efficacy and safety. Every provider must consider the words they use. Most patients don't like obesity, and there's nothing wrong with not using it. It's important to always link weight and health. So healthy weight, or let's talk about how your weight affects your health, are options. It's a good idea to have patients fill out weight history forms and other information before the visit begins. And we need to ask our patients about what concerns them most about their weight and what is the single most important outcome of their weight loss effort. We need to listen to our patients. Let's hear from one now.
Really, the only thing that I knew about this particular medicine was that it was an injectable. And I was a little nervous about that. Nobody likes to, go into something knowing that they're going to have to put a needle in them every single day. And I was also concerned about sort of the timing on, would I remember to take it? How do you remember to do an injectable? One of the things that was good for me, or I guess helpful for me in this case, was that when my daughter was going through chemotherapy, she had something called steroid-induced diabetes. And so she had to take an injectable during those months, and I helped her with that. So that gave me a little bit of an ease of mind, I guess, knowing that she said it didn't hurt. So I believed her. So that was sort of a concern of mine going into this. But other than that, I didn't really know much about how the medication worked. I'm still kind of confused about how it works. But that was sort of the discussion that I had with my primary care doctor.
Healthcare providers are underutilizing medications. In obesity, anti-obesity medications are prescribed to only 2% of eligible persons. In type 2 diabetes, 85% of eligible individuals are prescribed medications. Knowledge of contraindications, precautions, and common side effects are important. Orlistat is generally safe, but caution is needed in patients who require cyclosporin, and it should also not be used in chronic malabsorption or in cholestasis. Because orlistat blocks fat absorption after a high-fat meal or snack, steatorrhea can occur, and patients must be counseled. The most important thing to know about phentermine topiramate is the pregnancy warning. Topiramate is associated with cleft palate if taken in early pregnancy. No anti-obesity medication should be taken during pregnancy, but patients requiring phentermine topiramate should take a monthly pregnancy test and stop the medication should pregnancy occur. Contraception should also be used. Naltrexone bupropion should not be prescribed in uncontrolled hypertension, those with seizure disorders, and those who are drug and alcohol dependent. Naltrexone bupropion requires a dose escalation period because nausea is a frequent tolerability issue. Liraglutide and semaglutide, like all drugs in this class, should not be prescribed to patients with a family history of medullary thyroid cancer or multiple endocrine neoplasia type 2, or in patients with a history of acute pancreatitis. Liraglutide and semaglutide require a dose escalation because of nausea. And we need to remember the dosing instructions. Orlistat is taken orally 3 times a day before meals. Phentermine topiramate requires a dose escalation. The starting dose is 3.75 23 milligrams. Naltrexone bupropion also requires a dose escalation. The starting dose is 1 tablet a day. That's 8 milligrams, 90 milligrams. Liraglutide requires a dose escalation. It's given by injection, and the starting dose is 0.6 milligrams. Semaglutide is a GLP-1 analog given once weekly by injection. Semaglutide also requires a dose escalation. When we prescribe, there are 3 phases. We initiate therapy and titrate up to the highest approved dose based upon efficacy and tolerability. Then, in phase 2, we monitor efficacy, safety, and tolerability. We recommend seeing the patient monthly for the first 3 months, then every 3 months thereafter. And finally, we want to continue medications if they're effective and adjust them if they're not. Effectiveness can be observed by 5% or more weight loss in the first 3 months of therapy. If patients have achieved this amount of weight loss, we should continue. If not, we should discontinue and consider another medication. The most important thing to remember about weight management is to keep the patients coming back. Patients will be more successful with maintenance if they are followed regularly. There are some wonderful resources for primary care practitioners. The Weight Can't Wait resources. These are accessible at go.gwu.edu/WCW resources. Let's hear from a patient and hear what she would like to share with us.
I think my biggest advice in particular on this medication that I'm on is to really start very slowly and titrate up very slowly and understand that there is the side effect of nausea, but that it does go away. I feel like maybe people want this to be the magic bullet and we'll take it and there won't be any side effects and they'll be able to lose the weight really quickly. And that's not how it works. It definitely helps. It definitely moves you forward in a much faster way than without it.
Thank you, Christy, for sharing those valuable insights. So let's wrap it up. Lifestyle modification is the core intervention for weight loss, and modest weight loss, 5 to 10%, can produce health benefits. If we're able to produce greater weight loss, we can get even greater benefits. The biologic basis of energy intake and expenditure is complex, and only a small part of it is under conscious control. The body defends against weight loss. Loss of fat mass causes metabolic adaptations that can lead to weight regain. Several medications are available to help prevent weight regain. And incretin therapies addressing GLP-1 have been shown to reduce weight as well as promote satiety. Weight management requires individualized treatment and ongoing follow-up. That concludes this educational activity. Thank you very much for participating.
This activity is accredited by Medical Learning Institute, Incorporated. This activity is developed with our educational partner, PVI, Peerview Institute for Medical Education.